Now we'll move on to medium vessel vasculitis, starting with polyarteritis nodosa. So polyarteritis nodosa, just remember it is going to have a multi vessels involvement, and here the P will not go with P. So the P of polyarteritis nodosa will not go with the pulmonary vessel. So there will be no pulmonary vasculature involvement. So P and P will not go. That is how you remember it. So pulmonary vessels will be spared in PAN. Okay, and kidney can be involved in PAN. However, there will be no glomerulonephritis. There will be no glomerulonephritis in PAN. Why I am stressing this, you'll understand when I am discussing microscopic polyangiitis. So both of these diseases, if you read in comparison, you'll understand. So they have opposite kind of features. So PAN has kidney involvement, but there will be no glomerulonephritis, and it can be associated with hepatitis B in 30% of cases. So in the history, they might give a clue, as in the patient was hepatitis B positive. And most common vasculitis associated with mononeuritis multiplex is this PAN. So mononeuritis multiplex is normally associated with diabetes mellitus, but if they specifically ask for vasculitis, then it is going to be PAN. And there is no granulomas. So unlike large vessel vasculitis, there are going to be no granulomas, and nor there will be ANCA. ANCA is anti-neutrophil cytoplasmic antibody. So ANCA association will not be there. But in microscopic polyangiitis, there is going to be ANCA association. So that is why I'm mentioning here, PAN doesn't have any ANCA association. And microscopically, if you see, there is going to be segmental, that is only part of the vessel is going to be affected. So segmental, but a transmural, that is the entire vessel wall will be affected with necrotizing inflammation. So necrotizing is very important over here. So segmental, necrotizing, transmural inflammation. So this necrotizing will be any kind of vasculitis is usually associated with fibrinoid necrosis. So this kind of an inflammation will be present in the vessel wall. And the very important thing about this PAN will be, there will be suppose this was it was a vessel like this. So in this vessel itself, you can have various stages of the disease. So at the same time, all stages of the disease will coexist in the same vessel at the same time. So that is what is important about PAN. Moving on to the next medium vessel vasculitis, which is Kawasaki disease. So Kawasaki disease classically presents in children less than 5 years, and the history will be that of a myocardial infarction. Imagine myocardial infarction in a child. So that will always point towards the Kawasaki disease. Have that in mind. And here it is because the vessel which is being involved in the Kawasaki disease is coronary arteries. And here they are going to have anti-endothelial cell antibodies. So these antibodies are the ones which are going to attack the coronary arteries and cause the inflammation. So to diagnose Kawasaki disease, we have a criteria. So 5 out of the 6 criteria should be present for diagnosing Kawasaki disease. Firstly, there should be persistent fever for more than 5 days, and you will have bilateral conjunctival congestion. Along with that, you will have erythematous tongue, like which we call as strawberry tongue, and then we'll have erythematous rash in the palms. And other than that, you also have swelling or edema in the palms and the peripheral extremities. Other than that, you have lymphadenopathy, which is cervical lymphadenopathy more than 1.5 centimeter. So this is the criteria which we use for Kawasaki disease. And here there is going to be thrombocytosis. The platelet count will be increased in Kawasaki disease. So microscopically, if you see, again, it will be having segmental, transmural inflammation, which is associated with necrosis. So like that of PAN, same features only, but it is going to be seen in the coronary artery in a child. Next disease in medium vessel vasculitis will be Buerger's disease. It is also called as TAO, that is thromboangiitis obliterans. Okay, so don't confuse it with Buerger's disease. Here Buerger's disease will be actually IgA nephropathy. Okay, that is, there is no U here. So Buerger's disease and Buerger's disease are different. Remember that. Here the classical history will be that of a young male, less than 35-year male, who is a chronic smoker. So as the name suggests, thromboangiitis obliterans, there is going to be presence of a thrombus, and that is going to cause vasculitis. So angiitis is there, and when this thrombus is present, it is going to cause obliteration of the vessel. So when obliteration of the vessel is there, there is not going to be blood supply to the organs. So usually the peripheries will be affected, and the hands and the toes, right? So the fingers and the toes will be forming gangrene. So blackish discoloration of the fingers and toes will be seen in TAO. And there are classical HLA associations associated with this. So HLA A9 and HLA B5 are going to be associated with TAO, while HLA B12 is going to be protective for TAO. Okay, so another important feature about TAO is the patient will initially present with intermittent claudication. That is, the patient can walk for some time and then he'll have pain and then he'll take a rest. Then again he'll walk for some time and sit for a while. So this is the classical feature which the Buerger's disease presents, and this is because the inflammation is actually involving the artery and vein. But later on, this inflammation can start to involve the nerve as well. So when the nerves are involved, the patient will have pain even at rest. So without even walking, the patient is going to have rest. So that is a very important feature of TAO. Artery, vein and nerves can be involved, but lymphatics will never be involved. Then the most common arteries I already mentioned is going to be the peripheries, right? So on the leg, it will be tibial artery, and in the hands, it will be radial artery, which is going to be affected. Microscopically, what do you see? Like that of the vasculitis, any vasculitis, segmental vasculitis is going to be present. As the name suggests, thromboangiitis obliterans, obviously there is going to be a thrombus. But most of all, the very important feature is neutrophilic microabscess along with the granulomatous inflammation. Neutrophilic granulomatous microinflammation will be present, encasing both artery, vein and the nerves. So this is the classical features we see in a TAO.